Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to Neurology Made Easy. Today's video will be very interesting. It will be a bit longer than my usual videos, but I have tried to cover these topics that are very important, especially in cases where we see patient in neurocritical care. So the topics we are going to study today are Renin-Angiotensin-Aldosterone system, then we will study the role of ADH, that is antidiuretic hormone. Next, we will see that if there is lack of ADH, what happens, and diabetes, what is diabetes insipidus. Basically, we will talk about central diabetes insipidus. There are two types, nephrogenic and central. So my main focus will be on central diabetes insipidus, but I will also tell you how to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus. Then we will talk if there is increase in ADH and what is SIADH, syndrome of inappropriate ADH secretion. And lastly, I will tell you how to differentiate between SIADH and cerebral salt wasting syndrome, that is also called as Nelson syndrome. So today's video will be longer, but all of these topics are very important. But in case you want to see only a specific part of this video, I will mention in the description the timings of each of this section, so you can go directly to that part also if you want to see only that part. So let's begin. First, we will start with the Renin-Angiotensin-Aldosterone system. I have abbreviated it as RAAS. Renin-Angiotensin-Aldosterone system is very important because it is mainly involved in the fluid balance of the body and also to maintain the blood pressure. First of all, it starts that liver synthesize the angiotensinogen. Then it is converted, this angiotensinogen is converted into angiotensin 1. This happens with the help of renin, and renin is secreted by kidney, the juxtaglomerular apparatus of the kidney that secretes renin. Angiotensin 1 is later on converted to angiotensin 2 through the help of ACE, angiotensin converting enzyme. ACE is found in lung predominantly, but it is also found in vascular endothelium of kidney, brain and heart. So now I am drawing it. This I have tried to show liver, and it is synthesizing angiotensinogen. Then from the kidney comes the renin, and it converts angiotensinogen, that is an inactive form, to angiotensin 1. Angiotensin 1 is converted with the help of ACE to angiotensin 2. Now this angiotensin 2 has three major roles. First of all, it acts on the blood vessel and causes vasoconstriction. Second, it causes release of aldosterone from the adrenal cortex. And thirdly, it stimulates the release of ADH from the posterior pituitary. So here you can see that I am drawing a blood vessel, I have tried to show the adrenal cortex and the pituitary gland. So it acts on the blood vessel and causes vasoconstriction. It causes release of aldosterone from the adrenal cortex that later on results in increased sodium reabsorption in the kidney. And thirdly, it stimulates the release of ADH, and ADH is involved in reabsorption of water from the collecting duct in the nephron. So basically, when there is decreased blood volume and blood pressure is low, this system is activated, and from by these three mechanisms, vasoconstriction, there is increased peripheral resistance, increased sodium reabsorption, and increased water reabsorption. Thus, the blood volume is increased, and hence the blood pressure is also increased. So here I am again showing this pathway: angiotensinogen to angiotensin 1 to 2, and then the angiotensin 2 has these three functions. And major role is in the fluid balance. Now we will talk about the role of ADH, that is the antidiuretic hormone. In my previous video, in which we have discussed the hypothalamic hypophyseal portal system and hypothalamic hypophyseal portal tract, I told you in detail how ADH is released from the posterior pituitary. I'll just quickly recap that there is supraoptic nucleus in the hypothalamus. The cell body is in the hypothalamus, and the axon extends to the posterior pituitary. And here it releases this ADH hormone. ADH is also called vasopressin, and it has primarily two roles. First, I will tell you that how it is stimulated, the release of ADH is stimulated, and then I will tell you what are the two roles of ADH. So stimuli are basically the osmoreceptors. There are osmoreceptors present and in our CNS, and when they sense that there is, so the osmoreceptors, they are sensitive to plasma osmolality, and when there is increased plasma osmolality, there is a release of ADH. Moreover, when there is reduced BP, the renin-angiotensin system is activated, and the angiotensin 2 also causes the release of ADH from the posterior pituitary. There are two roles of ADH, as I already told you. First is that it causes the reabsorption of water, mainly from the collecting duct. We will discuss how it does so in few minutes. And the second function is vasoconstriction. It acts on the blood vessels and causes vasoconstriction. So when there is increased amount of ADH, then this vasoconstriction function is available. So now we will see that how this ADH causes the increased reabsorption of water from the collecting duct. So you know, the nephron, it has different parts. It has Bowman capsule, then there is proximal convoluted tubule, then we have loop of Henle, distal convoluted tubule, and there is collecting duct. So in this diagram, first I have drawn this pituitary, hypothalamus and pituitary, and I have shown these receptors, OR as osmoreceptors, and also the angiotensin 2 receptors. So in case these receptors are stimulated and it causes the release of ADH, this ADH will now act on the nephron. Now I am showing the tuft of blood vessel, that is the glomerulus, and you know, the glomerulus and Bowman's capsule, they are collectively, they are called as renal corpuscle. Here is the loop of Henle, distal convoluted tubule, and collecting duct. So I've just marked them: PCT, DCT, proximal convoluted tubule, distal convoluted tubule, and collecting duct and loop of Henle. So in the collecting duct we have principal cells. There are also other type of cells, but basically we are talking about principal cells. In these principal cells, there are receptors for ADH. So ADH binds to these receptors on the principal cells. So what happens that now I am showing you a enlarged version of one of the principal cells. So suppose this is a principal cells and we have ADH receptors here. So there are aquaporin receptors. Some are all the time present, while the others, they are actually placed in the luminal, towards the luminal membrane by the ADH, and hence there is increased reabsorption of water in the collecting duct. So I will explain later that there are different types of aquaporin receptors. Some receptors are present all the time and there is reabsorption of water, but to enhance this reabsorption, this ADH acts on the vesicles and the vesicle present inside the cell, and there is a process through which these extra aquaporin receptors, they go and they are placed towards the luminal membrane, and hence they cause increased reabsorption of water from the collecting duct. And when there is increased reabsorption of water, there is increase in volume. So I will repeat it, that when there is reduced blood pressure and there is increased plasma osmolality, there is release of ADH from the posterior pituitary. This ADH acts on the nephron and it causes water reabsorption. The other thing is that it also acts on the blood vessel receptors on the blood vessels and causes vasoconstriction. Hence, there is increase in the peripheral resistance. So through these mechanisms, there is eventually increase in the blood pressure. So our next topic is central diabetes insipidus. There are basically two types of diabetes insipidus, central and nephrogenic. Mainly we will discuss central diabetes insipidus. So there is a lesion, suppose there is a lesion in the posterior pituitary and there is a lack in ADH secretion, lack of ADH secretion. This results in impaired reabsorption of water from the collecting duct, and hence a large amount of water is excreted in the urine, and the urine we will have polyuria, and because we are excreting a large amount of water in the urine, there will be polydipsia. The patient will be thirsty. So this is basically what happens in diabetes insipidus. There are various causes of diabetes insipidus. We are talking about the central causes. There can be tumors such as glioma, craniopharyngioma, pituitary tumor, any massive pituitary tumor, metastasis can also be there. So and other tumors can also be present that causes the impaired secretion of ADH from the posterior pituitary. Next we can have granulomatous infiltrates such as sarcoid, eosinophilic granulomatosis. We can also have trauma as a cause of central diabetes insipidus. head injury can also be a cause. Rarely it can be congenital because of the developmental defect of supraoptic and paraventricular nuclei or defect in the posterior pituitary. Some drugs such as carbamazepine and lithium also cause diabetes insipidus. Now next I will tell you how we can differentiate between central and nephrogenic diabetes insipidus. Basically, in nephrogenic diabetes insipidus, there is impaired reabsorption and the defect lies within the kidney. While in case of central, we have central causes such as brain tumors, trauma, head trauma, I already mentioned. So what you have to do is you give 5 units of vasopressin subcutaneously. In case of nephrogenic diabetes insipidus, there will be no effect. While in case of central diabetes insipidus, there will be reduced urine output and the osmolality will increase. Next is that plasma, we can also test plasma ADH level. It will be less than 1 picogram per ml and normal is 1.4 to 2.7 picogram per ml. So if plasma ADH is low and by giving vasopressin this symptoms are improving, then it means that there is problem in the ADH secretion by the central nervous system. In treatment, we can give vasopressin nasal sprays. There also long-acting analog desmopressin is available in the form of nasal spray. In case of unconscious patient, we also can offer subcutaneous vasopressin and desmopressin. We should also monitor the input-output charting should be done, and serum osmolality and urine osmolality should be checked every 8 to 12 hours. For longer duration of action or in the form of oil, these can also be given, and that lasts 4 to 72 hours. Now the next is SIADH, syndrome of inappropriate ADH secretion. Now our topic is SIADH, syndrome of inappropriate ADH secretion. Blood osmolality is 282 millimole per kg and it has a very narrow range. Once we reach up to 287 millimole per kg, so 287 millimole per kg, that is called osmotic threshold, and once we reach that threshold, there is the release of ADH, that is antidiuretic hormone. Plasma level of ADH is 2 picogram per ml. Increase in osmolality causes increased ADH release till a balanced state is reached. So what are the causes of SIADH? Brain infarct, bleed in brain or brain hemorrhage, tumor, trauma, infections such as encephalitis or meningitis, any CNS surgery, GBS, Neoplastic lesions such as small cell lung carcinoma, that is paraneoplastic lesion, and they call they cause release in ADH. There are also various drugs such as carbamazepine, chlorothiazide, clofebrate, chlorpromazine, chlorpropamide, NSAIDs, and vincristine that causes syndrome of inappropriate ADH secretion. Important thing is that in the criteria of SIADH, both hypothyroidism and glucocorticoid deficiency must be ruled out. Moreover, there should be no renal failure or there should be no use of diuretics. Patient should have a euvolemic state. Then there are other lab criteria such as plasma osmolality should be less than 270. In some places it states 280, but majorly it's 270 milliosmoles per kg of water. Plasma osmolality should be less than 270. Urine osmolality should be more than 100 milliosmoles per kg. Then urinary sodium should be more than 40 millimole per liter. So here I am mentioning the labs. Here I have written 300 milliosmoles, but mostly I have read in other places it's 100, more than 100 milliosmoles per kg. But 300 I also found it somewhere. In urine osmolality, here I have written less than 280, but I have also read less than 270 in some book. There are a little bit difference in the values in different books, and as I consult different books, so sometimes there is discrepancy, but it's not normally all of the time, but sometimes. Okay, serum sodium is less than 135 millimole per liter. This is reduced in blood urea nitrogen and uric acid, and there is no tissue edema. So this is the criteria of SIADH. The signs of SIADH, there are vast majority of signs and symptoms ranging from confusion and stupor to coma. There can be movement disorders such as tremors and myoclonus. There can also be gait disturbance and ataxia. Nausea and vomiting can also be present. Then we can have generalized seizures also. Hyporeflexia can be present, and breathing pattern can also be disturbed. Mostly these symptoms are visible or they are present when there is sodium level less than 120 milliequivalent per liter. So now we come to the treatment. The main rule of treatment is that slowly correct serum sodium level. I have written it in large font because I want to make this point very clear, because once we correct the serum sodium level very rapidly, it can result in central pontine myelinosis. So in that way we will be doing damage to the patient by ourselves. So we are causing damage to the patient instead of giving benefit or treating him. This is not a correct practice. So the main point is slowly correct sodium. So safe rule is that sodium should sodium should not be increased more than 12 milliequivalent per liter in the first 24 hours, and it should not be more than corrected more than 20 milliequivalent per liter in 48 hours. So don't forget, slowly correct sodium. These things look very simple, but they have a large amount of impact on the treatment. So now coming to the treatment, that if there is serum sodium is between 117 to 125 milliequivalent per liter, then restrict the fluid. We can reduce fluid such as 400 to 800 ml per day. The other thing is, if serum sodium is from 110 to 115 milliequivalent, then we can give hypertonic saline, that is 3% sodium chloride. But with that we have to give also a furosemide, that is a loop diuretic, so that we avoid the fluid overload. So it's difficult for the non-native English speaker to understand when I talk a bit faster. That's why I intentionally talk in a slow pace, so that each of you can understand. So now we come to the last part. It is cerebral salt wasting syndrome. And I will tell you how to differentiate cerebral salt wasting syndrome and SIADH, because sometimes they are similar looking, but the management is totally different. I will explain you. So cerebral salt wasting syndrome is also called Nelson syndrome, and what happens is basically there is atrial natriuretic factor, and this factor is released by the cardiac atria. In our heart we have cardiac atria, so it is released by cardiac atria, and it is also released by the neurons around the third ventricle and the hypothalamic region. So these are the two sources of ANF, and ANF causes increased sodium loss in urine. So there is hyponatremia because there is increased sodium is lost in the urine. The causes of cerebral salt wasting syndrome can be stroke, hemorrhage, can be tumor, brain tumor, trauma, can be surgery, dysautonomic regulations. In GBS also we have dysautonomia. It can be TBM, tuberculous meningitis, injury, head injury. So you have seen that more or less the causes are almost same in these conditions we are discussing today. So management is basically fluid balance, and we can give normal saline if there is hyponatremia. So now I will tell you how to differentiate cerebral salt wasting syndrome and SIADH. So in both of these conditions, this urinary sodium is more than 40 milliequivalent per liter. But in one, that is SIADH, there is increase in the fluid level of the In SIADH, there is increased reabsorption of water from the collecting duct because of the ADH, and hence there is dilutional hyponatremia. While in case of cerebral salt wasting syndrome, there is ANF, atrial natriuretic factor, that is causing sodium loss in the urine. So there is true hyponatremia basically because of loss of sodium. So what we do is we calculate the urinary sodium excretion, and the formula is that urinary sodium concentration in milliequivalent per liter into urine volume in liter per 24 hours. So we calculate this, and if this urinary sodium excretion, it is more than sodium intake that is present in cerebral salt wasting syndrome. But when it is equal to the salt intake, excretion of sodium is equal to the intake, it happens in SIADH. So basically net sodium is intake minus output is negative, that is sodium loss is more as compared to the intake, and we call it negative balance, and this is present in cerebral salt wasting syndrome. So I hope you have liked this video, and if you have liked it, share it with your friends and subscribe if you have not subscribed it yet. Take care, keep smiling. If you have any question, you can write in the comments, and next video will be published soon, inshallah, and it will be about emotions, that how we feel sad, happy, or whatever, and our behaviors such as feeding behavior, sexual behavior, motivational behaviors, and sleep wake cycle. So next video will be that, and after that we will do some movement disorder. I will make videos on movement disorder and some research topics, so stay tuned, and give your feedback too. Thank you. Allah Hafiz. Take care.